Welcome to Section 6 of the Acid-Base Physiology Review. In Section 6 we will go into more detail into metabolic alkaloses, including clinical presentation, classification, and introduction to treatment. Welcome to Section 6 of the Acid-Base Physiology Review. In Section 6 we will walk into more detail of metabolic alkalosis, the differential diagnosis, as well as a little introduction to treatment. Recall that a metabolic alkalosis is once again a process that causes a primary increase in bicarbonate concentration. Metabolic alkalosis can be generated by either a loss of acid or a gain of bicarbonate. The kidneys normally have a large capacity to excrete bicarbonate, so abnormal renal retention of bicarbonate is required to maintain a metabolic alkalosis. Metabolic alkaloses tend to have two phases, the generation and the maintenance phase. The generation phase comes from the loss of hydrogen or gain of bicarbonate. However, the maintenance phase must exist when there's abnormal renal retention of bicarbonate or increased acid excretion, even in the setting of alkalosis. The general classification of metabolic alkalosis is according to the mechanism that maintains the alkalosis. The vast majority of alkaloses are associated with hypokalemia. The two classifications primarily used are saline-responsive metabolic alkalosis versus saline-resistant metabolic alkalosis. The differential for metabolic alkalosis is as follows: extracellular fluid volume depletion, hypokalemia, mineralocorticoid excess, Gilman syndrome, Bartter syndrome, or iatrogenic, meaning excess bicarbonate administration. Let's first talk about the saline-sensitive form. These are also known as the saline-responsive or the chloride-responsive metabolic alkalosis. These are far the most common, with greater than 80% of metabolic alkaloses being the saline-sensitive form. The saline-sensitive metabolic alkaloses are caused by extracellular fluid volume contraction as well as chloride depletion. The most commonly encountered is in the setting of vomiting or, from an iatrogenic standpoint, nasogastric suctioning. Also, chronic diarrhea or laxative abuse as well as chronic diuretic abuse causes chloride depletion and extracellular fluid volume contraction. The increased sodium bicarbonate reabsorption in the proximal tubule from the volume depletion maintains the alkalosis. This also stimulates renal potassium loss through the increased activity of aldosterone. The hypokalemia serves to maintain the metabolic alkalosis even further. Saline-sensitive forms are corrected by the infusion of normal saline as well as potassium chloride. Important to remember, while volume expansion is necessary to treat saline-sensitive metabolic alkaloses, it is very difficult to correct them completely without correction of the hypokalemia, as the hypokalemia, as we stated before, will increase ammoniogenesis and increase net acid excretion. If the hypokalemia is not corrected, this will perpetuate the metabolic alkalosis. The clinical clue to a saline-sensitive metabolic alkalosis is a low urine chloride, usually less than the measurable range of a laboratory, or less than 25 milliequivalents per liter. There are also saline-resistant forms of metabolic alkalosis. The prototype are the mineralocorticoid excess syndromes, either primary or secondary hyperaldosteronism. Also, Cushing's syndrome, because of its mineralocorticoid excess, can manifest as a saline-resistant metabolic alkalosis. Once again, severe hypokalemia is the rule. Two inherited syndromes, Gilman syndrome and Bartter syndrome, which act like thiazide and loop diuretics respectively, can also cause saline-resistant metabolic alkalosis. Finally, there can be an iatrogenic metabolic alkalosis that's maintained by renal failure. If increased bicarbonate is administered and there is decreased capacity of the kidney to excrete bicarbonate, or the patient is dialysis dependent, then the bicarbonate concentration will remain elevated, and a metabolic alkalosis will persist. The metabolic alkalosis in saline-resistant forms is caused by two primary disorders. Potassium depletion shifts hydrogen into cells, stimulates proximal tubular reabsorption of bicarbonate, as well as increasing ammoniogenesis and ammonium excretion. Also, increased aldosterone activity stimulates distal nephron hydrogen secretion and further causes loss of urinary potassium. Normal saline infusion will not correct these metabolic alkaloses and requires correction of the underlying defect. The clue in this instance is the opposite of the saline-sensitive forms, meaning the urine chloride concentration tends to be elevated, usually greater than 40 milliequivalents per liter. Let's go back to case 3. The urine sodium concentration is 5 milliequivalents per liter, the urine potassium concentration is 40 milliequivalents per liter, and the urine chloride concentration is 1 milliequivalent per liter. If you recall, this patient had a metabolic alkalosis. How would you use these values to determine whether this is a salt-sensitive or salt-resistant alkalosis? As we said, the urine chloride is the key. The urine chloride concentration, in this case, is extremely low, suggesting this is a saline-sensitive metabolic alkalosis. Thus, administration of normal saline in volume expansion with correction of the hypokalemia should correct the metabolic alkalosis.